All right, so get ready because today we're really diving deep into what happens after someone's heart actually stops, the care they get.
Yeah, fascinating area.
You sent us this article, Management of Patients After Cardiac Arrest, and wow, there is a lot to unpack here.
It's amazing, isn't it, how much we keep learning in this field. Every little bit of research seems to have such a huge impact on how we can actually help these patients.
And it's not just like theoretical medical stuff. It's about a health crisis that I think most people don't even realize how big it is. Almost 350,000 people in the US every year have a cardiac arrest, and that's just the ones that happen outside of a hospital.
And that's a really important distinction. Out-of-hospital cardiac arrest, OHCA, that has a survival rate that's way lower than if it happens in the hospital. So when you talk about those folks, they're facing, what, single-digit chances of making it? It really emphasizes just how crucial the care is once they reach a hospital.
It's kind of a scary thought. Only about 10% survive OHCA and around 27% for in a hospital, the IHCA. And even then, full recovery, neurologically, it's not a guarantee. So let's break down what happens when someone does make it to the hospital, heart stopped, then what?
Well, it becomes a lot more than just, jump-starting the heart again. This article, it really focuses on something called post-cardiac arrest syndrome, and it's this whole domino effect of problems that can hit the entire body.
Yeah, and here's where it gets kind of, wait, what? Because they're saying that the act of actually saving someone, like doing CPR, that in itself can cause injuries.
Yeah.
Makes you realize the force of those chest compressions.
It's a necessary force, though. I mean,
Yeah.
you need that to keep the blood flowing. But like they say in the article, that force, it can lead to the obvious stuff, broken ribs, but also things you wouldn't expect.
It's not just ribs or the sternum, they were saying. It can be deeper organ damage, liver, lungs, even the spine. Being a lifesaver, rough on the body, apparently. So thorough examination, that's gotta be key.
Absolutely. And they talk about CT scans being so important to catch these injuries that are often missed otherwise. One study they cited found a significant number of patients had critical findings on their CT scans that they wouldn't have caught otherwise.
So, okay, we've got a patient, they've survived cardiac arrest, maybe some CPR complications. What's the very next thing?
Protecting the brain. That becomes priority number one. See, when the heart stops, the lack of oxygen, it can really damage the brain. And then to make matters worse, when the blood flow returns, that rush of blood can actually cause further injury. Kind of ironic in a way.
Which is where I guess targeted temperature management comes in. This TTM thing, it sounds kind of sci-fi, like from a medical thriller.
A little bit. It's basically very carefully controlling the patient's temperature. For a long time, inducing hypothermia, like really cooling the body down, that was the standard. The idea was it could slow down the brain's metabolism, reduce that damage.
Makes sense when you hear those stories of people surviving crazy stuff like avalanches or falling into frozen lakes. They're clinically dead, then they recover. So slowing down the body, maybe there's something to that.
Exactly. But here's where it gets complicated. Those early studies, promising.
Hmm.
But bigger trials later on, like the TTM trial in 2013 and the TTM2 trial in 2021, they didn't find those same benefits for survival or brain recovery. Some even suggested maybe it could be harmful.
So is that it for TTM? No more hypothermia?
Not so fast. What these big trials seem to show is that preventing fever, that's key. Maybe even more important than the hypothermia itself. Keeping patients at a normal temperature, active normothermia they call it, that might be better for most.
But like most things in medicine, I'm guessing it's not always that clear cut. The article did mention a few specific cases where hypothermia might still be the way to go.
Right. One group they seem to benefit from cooling are those patients who had a non-shockable heart rhythm during their cardiac arrest.
Hold on, need a quick explanation there. Non-shockable rhythm, what's that mean and why would it change things?
Good question. It means their heart wasn't in a rhythm that you could shock back to normal with a defibrillator. These rhythms, they often mean the heart is just kind of quivering, not effectively pumping, and that's way tougher to treat. So for those patients, cooling, it might give some added protection. The other group that might benefit are those who didn't get CPR right away.
So if CPR wasn't immediate, their brain was without oxygen, longer, more vulnerable, so cooling makes more sense then.
Exactly. So preventing fever, super important, but still those questions about hypothermia, should it be more selective? It's a delicate balance, weighing the good and the bad for each person.
Which then gets us to another layer, sedation. How much should these patients get, especially if we are talking about cooling them down? Because that can't be comfy.
You're telling me.
Yeah.
And the shivering the body does to try to warm back up, That works against the whole cooling process.
Like fighting the thermostat? Someone's got a space heater going full blast while you're trying to cool down the room?
Perfect analogy.
Yeah.
But yes, sedation, not much research on it specifically.
Yeah.
But we do know that deep sedation has been part of a lot of TTM protocols, especially with hypothermia.
Which goes against what we hear in other areas, like critical care in general, where less sedation is usually better, right?
You're right. It is interesting. But here's something they brought up that's interesting. Those studies where cooling DAD seemed to help, they also used more sedation. So maybe sedation, especially deep sedation, plays a bigger role than we thought.
Now that is interesting. So are we saying put them in a deeper sleep could actually be protective for the brain?
It's possible,
Mm.
but more research is needed. Right now, the thought is deep sedation for everyone, probably not the best. Shorter acting sedatives, that might be better. Lets us do those neurological assessments sooner.
Makes sense. You want to be able to wake them up as soon as it's safe and see how the brain's doing. Which I guess leads us to that huge task of neuroprognostication, trying to predict how much brain function someone will regain after this. That's got to be one of the toughest parts. It's like you're trying to predict the future almost with how the brain's going to bounce back after something so major.
Yeah, no, it's a huge responsibility. And even with all the technology we have, it's still a challenge, definitely.
The article mentioned like waiting at least 72 hours after rewarming before you really try to make any solid predictions about, neurological recovery. Seems like those first few days are really make or break. So what are the doctors actually looking for during that time?
Well, they're watching for any signs of brain activity, any recovery, anything. One of the first things they check are the pupils, like how do they react to light. That capillary response can tell them a lot about how the brainstem is doing.
So if the pupils constrict when the light's shined in, good sign.
Exactly. It means the brainstem, which controls all those basic vital functions, is working. But it doesn't stop there. Brain imaging, like CT scans, MRIs, those can show if there's any structural damage. And then there's the EEG, which measures electrical activity in the brain.
Oh, right, with the electrodes on the scalp, like they're trying to listen in on the brain's signals.
That's it. It's another piece of the puzzle. And then they also use something called sensory-evoked potentials. Basically, they're looking at how the brain responds to different sensations, sounds, touch, that kind of thing.
So it's like putting together a puzzle, all these different tests, trying to get the full picture of what kind of recovery is possible.
Precisely. And even with all that, it's not an exact science. The brain is incredibly complex, and its ability to heal, to adapt, it can be unpredictable. Imagine like a rainforest complex with hidden pathways, always changing. Even with all our technology, we're still discovering its amazing ability to heal.
Makes you realize, even with all our medical advances, some things you just can't fully predict. So much of it comes down to the body's own power to heal.
Absolutely. And while the neurologists are doing all that, the rest of the team is focused on, keeping everything else running smoothly. We talked about temperature, but stable blood pressure, oxygen levels, those are critical too after cardiac arrest.
Yeah, I mean, the heart's beating again, but the body's been through this huge trauma.
Right. Think of it like a car engine, just been completely overhauled after a major breakdown. You got to make sure everything's working together again. There's actually been a lot of debate about the ideal blood pressure after a cardiac arrest. The BOX trial you mentioned, that really changed things.
It's not just keep it above a certain number and you're good.
I wish. But that BOX trial, it found that there wasn't a big difference in outcomes between two different blood pressure targets. The main thing, preventing hypotension, dangerously low blood pressure, that's what matters most. After that, it's about figuring out what's best for that specific patient.
So less about a magic number, more about finding that sweet spot for each person.
Exactly. Things like cerebral blood flow, how much blood is getting to the brain, intracranial pressure, pressure inside the skull, all that can vary.
So it becomes very personalized medicine, constantly monitoring, adjusting based on the individual's needs.
You got it. Now, while all this is happening, another crucial part is figuring out what caused the cardiac arrest in the first place.
Because if it was a heart problem, that needs to be addressed, right?
Yeah.
To prevent it from happening again. It's not just about surviving, it's about staying alive.
Exactly. That's where coronary angiography comes in. Let's doctors get a look at the coronary arteries, the ones that supply the heart muscle, see if there's any blockages.
And the article made it clear, doing this quickly, that's super important.
Especially for patients with what we call ST elevation on their EKG. EKG, that's like a heart rhythm reading. ST elevation, that's a huge red flag, means a major blockage, needs immediate attention.
And if they don't have that warning sign, what happens then?
Even then, urgent angiography might be needed. Say, if there are signs of ongoing heart damage, irregular heart rhythms, blood tests showing muscle damage, anything like that. It's a judgment call, weighing those risks and benefits. Like a detective trying to find what made the heart stop in the first place.
It seems like the theme here is time is of the essence.
Absolutely. Early detection, early intervention, those are key to better outcomes. Every minute matters.
Which leads us to something sensitive but really important. Not everyone makes it through this. And even if they do, recovery looks different for everyone.
That's right. And that's why this article really emphasized having those open, compassionate conversations with families about goals of care, end-of-life decisions, and doing it early on.
Those are never easy discussions to have.
Incredibly difficult, but so important. Making sure the patient's wishes are respected and that the family feels supported during what is a very stressful and emotional time. Making sure everyone's heard.
It really shows you the human side of all this, doesn't it? Not just medical charts and machines, but people going through something incredibly difficult and needing that support all the way through.
Absolutely. And that's where I think this multidisciplinary approach they talk about, that's so vital. It's not just, the heart doctors, the critical care folks. You've got neurology, palliative care, social workers, even ethicists sometimes. It takes a team.
And speaking of having the best people on the case, this article, it really drove home for me how far we've come with post-cardiac arrest care. We're talking about restarting hearts, stabilizing people who were minutes ago, at death's door, and understanding more and more about how the brain recovers from injury. It's amazing.
It really is remarkable how far we've come. But like we were saying, there's still so much we're learning. That's what makes this field so interesting.
And never stops, does it? That push to learn more, do better.
Exactly. And the more we uncover, the better the treatments will be, the better the odds for these patients.
It's a message of hope, I think, even when you're dealing with something as scary and unpredictable as cardiac arrest. And on that note of pushing boundaries, I remember that question at the end of this article really got me thinking about personalizing those cooling and sedation strategies we discussed based on the patient themselves.
Now that would be revolutionary. Imagine tailoring the treatment that precisely to really give each person their best chance.
Amazing to consider. Makes you realize this deep dive we've done, it's just scratching the surface. There's so much more to learn, to discover.
It's true, and I think that's an important takeaway for anyone listening. Knowledge is power, right? The more we understand about cardiac arrest, the better equipped we are to ask the right questions, advocate for ourselves and our loved ones, make those tough decisions if we have to.
Couldn't agree more. Thank you for joining us for this deep dive. It's been, well, eye-opening to say the least. Makes you appreciate the complexity of it all, but also feel hopeful about the future of cardiac arrest care. Even when things seem their bleakest, there's always reason to keep fighting for every beat.